everybody. Thank you very much for staying for the first student presentation at the conference. My name is Elisabetta Campagna. I'm a PhD student at UCLA. Today I'm going to present this work which is co-authored with Jacopo, who's also a PhD student at UCLA, and Paolo Giuliano. So this work is still a work in progress. So if you have any feedback or any questions, feel free to tell me. And we're going to study religious beliefs as a cure for HIV, and in particular focus on Pentecostalism in sub-Saharan Africa. So the motivation for our work started from learning about this new Christian denomination, Pentecostalism. It was founded in the early 1900s, and it very quickly became a mass phenomenon. Now, Pentecostals amount to at least a fourth of all Christians worldwide, which means that they are the most numerous group after Catholics. And they have a huge representation in public life and politics worldwide, with some recent economics contributions about the role of Pentecostals in South American politics. Perhaps like less well-studied context is that of Africa, where Pentecostals still are a very important group, amounting to about 17% of the population. So when reading about these facts, we started wondering, what is it that makes Pentecostals so successful worldwide, across age groups, across income groups, across cultures? And for the case of sub-Saharan Africa, we're going to test the hypothesis that the HIV pandemic played a role in their success. And I'm going to be more specific about how we do it later. So before jumping into the core of the project, I wanted to just give you an overview of who are Pentecostals. So Pentecostals are a Christian group that is made up of several relatively independent churches that, however, follow some common elements. So they're a Christian group that believes in the literal interpretation of the Bible, and they engage in practices such as miraculous behaviors, speaking in tongues, prophesying, divine healings, which are the core of Pentecostal doctrine and the experience of a Pentecostal mass. In general, the doctrine seemed to be built around the idea that religion must serve very practical ends, so they're very engaged in social programs addressed at poverty, underemployment, and lack of education, which makes them very present in disadvantaged areas. This goes hand in hand with the so-called prosperity gospel, which is a focus on individual ambitions and aspirations in Pentecostal doctrine. And anecdotally, recent literature has underlined this possible link between Pentecostals and support to HIV-infected people, which in sub-Saharan Africa represents one of the areas of biggest disadvantage. So with this paper, what we're going to do is we're going to ask if Africans in partly responded to the HIV pandemic by converting to Pentecostalism. So what I'm going to show you today is two separate exercises that we have done so far. The first one is some correlational analysis using the DHS data. This gives us a sample of observation across the entire sub-Saharan Africa subcontinent, which helps us show that this relationship is strong and seems to be not to be driven by any particular area or social group. And in this, I'm gonna show you how results seem to be driven by women in rural areas, and then I'm gonna turn to individual level evidence from a longitudinal study. This is going to be where we're going to be able to say more about causality and mechanisms, because we are observing individuals over time. And so we're able to say, delineate a timeline that goes from getting HIV infection into becoming Pentecostals in later rounds of the survey. So very briefly, we think that this paper relates to a couple of strands of the literature. Obviously, the literature on the economics of religion, where we're studying the determinants of take-up of Pentecostalism. Then there's recent work on Pentecostalism on South America and a little bit on Africa. Our paper would be, together with the Costa et al., the only one trying to understand the determinants of such a big success. The Costa et al. Paper focuses more on economic insecurity, and instead we're going to exploit health risk as a possible other determinant of religious take-up. And then more generally, it contributes to the literature on HIV in Africa and the literature on cultural change. So with this, we would like to introduce this paper that brings in the idea that a religion can be thought of as a behavioral response to the HIV pandemic. So the first part of the presentation is the correlation analysis in the DHS. So the DHS is a demographic and health survey. It's a household survey with individual level questions on health conditions, fertility, and a host of individual level characteristics. Importantly, the people in this survey, when they survey individuals, they take HIV biomarkers, so they test people for HIV. So in this case, we know if any respondent is HIV positive or not at the moment of the interview. In this study, we restrict our attention to the subsample of country waves for which we have both HIV biomarkers and a detailed enough religion variable that we can code up so that we can identify Pentecostal churches among the other possible denominations that the respondents can mention as their main religion. This gives us a sample of about 300,000 individuals scattered around 16 sub-Saharan African countries. Now, this is going to be a simple OLS. So with this specific analysis, we're not going to be able to say what's the timing. So if people convert to Pentecostalism and become HIV positive afterwards or vice versa. But we're going to be able to exclude mechanisms of reverse causality with some robustness that I'm going to talk about later. So what we're going to do is we are going to regress a dummy for being Pentecostal on HIV status, controlling for individual level controls. And what we have is a strong and significant and stable coefficient that tells us that becoming HIV positive leads to about a 10% increase in the probability of reporting yourself as being Pentecostal. Now, as I was saying, we do a bunch of robustness in this case. So the first thing that we do is we exclude reverse causality. So we do not find evidence that these people, perhaps because of features of their doctrines, are more likely to engage in riskier sexual behaviors, like not using condoms or maybe having multiple partners. That's not something that we see at all. The relationship is not driven by outliers, like not driven by any particular DHS cluster or region. We change slightly our specification to only using Protestants as a control group because maybe they're the closest, and that doesn't really change. Importantly, something that we're going to investigate further with the longitudinal study is the fact that all of the results that I showed you seem to be driven by women and rural areas. So when we split the sample by gender, we see that the coefficient for men is basically 0, and all of the 10% increase that I showed you earlier is entirely driven by the sample of women. And the same when we divide by urban-rural, the coefficient for the urban sample is 0, while that for the rural sample is strong and significant. So as I was saying, with this data, there's not much that we can,
Sorry, this is really a clarifying question. If you go one slide back to the table.
To the, that's the...
no, just the main table. So HIV status, if you're, what is the coefficient status exactly? If you have HIV, you're 1%?
So the mean of the dependent variable is 0.15.
Right.
So it's like a 10% increase.
So it's 1 percentage point, but 10%.
10%.
To the mean.
Yeah. Yes, exactly.
What's the fraction of people which are?
Pardon?
What's the fraction of people which are?
I should know it, but I can't remember exactly because that varies a little bit, but yeah.
I guess a general question, answer later. It's just to what extent, super interesting, but to what extent the general magnitude of HIV and the rise of
translates into, yeah. We did it, but I forgot, and so I should go back to those tables and refresh my memory. Yes, that's a good point. So the main limitation with this table, as I was saying, is that because HIV status and Pentecostalism are elicited at the same time. So at the moment of the interview, we're not really able to say much about causality. So what we do is we turn to this longitudinal study. So this longitudinal study is run in the Manicaland province in rural Zimbabwe. And the way it works is it's very similar to the DHS. So they collect HIV biomarkers. They ask several questions about demographics and so on. But importantly, they follow individuals over time. And this is really what we're going to exploit to be able to say something about the direction of causality. What we're going to use is 3 rounds. Because after round 3, they had to cut for budget reasons the longitudinal dimension. So most of the people and in the original 3 rounds disappeared from the sample, which prevents us from exploiting this longitudinal dimension further. But with 3 rounds, what we can do is we can regress each individual's Pentecostal dummy on whether they had HIV in the round before. So this excludes the possibility that the direction of causality is the opposite, so from Pentecostalism to HIV. So now what we do here, so in the first 3 columns, I'm regressing the lagged HIV status, Pentecostal on lagged HIV status, and we see the same pattern where we see a strong and significant coefficient for the full sample, but it's really driven by women. And then in the last 3 columns, what we do is we add a lagged Pentecostal dummy. So here we're really focusing on the people who report to have changed their religion toward Pentecostalism and were HIV positive around before. Yeah.
Are we going to talk about selection into sample and survival bias, which in your case is literal survival bias, that you only capture over time people who have not yet died from HIV, even though they have HIV?
Yeah. So we're working with the survey people exactly to get a sense of how many people get out of the study because maybe they die. This doesn't seem to be a huge number when we talk to them, but it's something that we're inquiring further. Yeah.
Just one question, clarifying again. So the random variable is expected value of being Pentecostal.
It's a dummy that equals 1. Yeah.
So the right. But instead of being the probability. So if you run a fixed effect logit, you have different results. Have you tried?
I think we did it with the logit and we didn't get very different results.
Okay.
But yeah. Yeah.
So is it something special about HIV, or you can replace HIV with any kind of disease or sickness?
This is a great question. So the way we approached the project was we were hypothesizing that Pentecostals were particularly good at tackling insecurity and disadvantage in general. So we had a story in mind about how their presence in disadvantaged areas really meant that they were good at tackling unemployment, economic downturns, and so on. And so we turned to health risk, thinking that this could apply to most types of health risk, but we focus on HIV because it is a particularly big phenomenon in sub-Saharan Africa. And so we thought there would be a big candidate for this. And also there's a lot of HIV studies that follow individuals over time and so on. So that would be one of the illnesses for which there's very good data that allows us to explore it. But yeah, it's possible that other types of illness have the same effects. So then something that we can do, given that we have this longitudinal dimension, is using individual fixed effects. This is obviously allowing us to control for whatever it is fixed within the individual, but we think still it is quite compelling that keeping the same specification, but in adding individual fixed effect instead of individual level controls, we find the same results, with women being particularly likely to becoming Pentecostals once they get HIV. Something that we're also able to show is that there is no evidence of reverse causality, so we do exactly the reverse of what we're doing. So we regress HIV status on lab Pentecostalism, and we do not see any effect. And then we do a bunch of other robustness checks. So we check if people, after becoming HIV positive, they seem to generally be joining social groups of any kind, like hanging out more with their community for whatever reason. That does not seem to be driving the results. We do also not see people experiencing major life changes as a result of getting HIV. And we do not see conversions to other denominations. So it seems to be something specifically about Pentecostals that is appealing to HIV positive people, because we do not see religious mobility as a result of HIV. Yeah.
So do you know what are the original religions? So what are they turning from?
Yeah. So we started looking a little bit into that. So it seems to be a context with relatively high religious mobility in general. Importantly, it's a context where most people declare themselves to be religious people. So here the question is not whether to be religious or not. So it's not the extensive margin. It's really like religious choice. So which type of religion you select into. I think we saw most conversions coming from other Christian groups, but it's something that we would like to exploit a little bit further to be able to sell more of that. Yeah.
But I figure out that's the thing. So I think like one of the interesting things in this setting is like sort of, I guess like the expansion of Pentecostal Christianity in Africa is like major sort of changes in like recent history.
Yeah.
But it, like in the macro sense, like it's occurring and has like sort of living standards and conditions in Africa moving. So I guess I'm curious, like that motivates the question about like whether this is like sort of the demand side of this. Maybe like Pentecostals are very aggressive about it.
Yeah. Yeah. Yeah, this is actually a great question, because this is exactly what we're in the process of studying right now. So the work in progress part of the paper is twofold. So the first thing is we want to explore a little bit more like what exactly is appealing to women and not to men in the Pentecostal doctrine after they get HIV. One idea that we have is Pentecostals seems to be having this redemption narrative that's like, we know you have sinned in the past, which caused you to get an STD. We're going to be able to redeem you from whatever sins you made in the past. And we think this might be particularly appealing to women in gender-biased societies. The second part of the paper, of the work in progress, is exactly what you're saying. So we wanted to look at the supply side, because we do think that Pentecostals might be particularly attentive to where HIV spreads and react accordingly. So we have gathered data on Pentecostal healthcare facilities from the Seventh-day Adventist yearbook. Seventh-day Adventists are a big Pentecostal church that has amazing data from like the 1900s on their granular presence in sub-Saharan Africa. So what we're doing is we're building this time series where we have the pins on the map, and we want to contrast it with the progression of the HIV pandemic and see how they reacted to that, and if this is sprouting out usage of other healthcare facilities and so on. But this is precisely where we're going. Yeah.
Because that's only to take care of the healthcare facilities. If you think about the social capital that built the church, but you can also see that how much the donation of the resources of these churches,
yeah, right,
all the time, and so that gives them the opportunity to build this social capital.
Yeah. Yes, I'm not. I'm not aware at the moment of data on that, but we will be looking for that. With this data, we also have their presence in terms of churches and educational facilities. So we want to exploit all three of them. But yeah, it would be nice if we could contrast it with donations. Yes, I agree. Yeah, I think I might be out.
Yeah, let's take the last question.
Okay, I think it's great to have granular data, but here I would also do the less granular version of this, which is what happens to the effect of the share of people who get HIV in the communities, like it's sort of a small village. So I think that naturally there's some strong spillover. So if you see people around you who get HIV, that may push you more towards the religion, and that could give you a larger effect overall because that could affect anyone in the community.
Yeah, well, we explored a little bit of the heterogeneity by HIV prevalence, but maybe we can talk a little bit more about that afterwards. But thank you.
Okay.
Thank you very much.